Good morning, everyone, and welcome to session 3 of our 2025 ACR virtual meeting. And just a few housekeeping reminders. We've been approved for 8 CE hours, of which 2.75 are designated Category A CE hours. This workshop does not qualify for CEIP credit, but keep your eyes on your email inboxes because I will be sending out some information soon about an upcoming opportunity where you will be able to earn CEIP credit for those of you who are looking to get some of those credits before your recertification is due. So what's on the agenda today? Well, after I do this little housekeeping section, we're going to hear from Georgia Yee, and she'll be talking to us about any Arizona Cancer Registry updates from this year, and she has some great information in that presentation. And then that's going to be followed by our epidemiologist, Dana Doyle, who will be talking to us about Arizona's cancer burden and cancer registry data usage. So I'm really excited to hear about some of these data requests that we've had. And finally, we're going to be hearing from our operations manager, Raeann Robinson, and she'll be giving us an update on what's going on with our operations team and with our transitioning over to WebPlus. So that is the agenda for today. Please use the chat for any general questions or comments, for communicating with one another, or for any technical questions that you might have. And of course, just a reminder that what you post in the chat can be seen by everybody else in the webinar. So we just ask you to be respectful, professional, and thoughtful when you make your comments. We also have a separate Q&A chat where you can ask your questions. That's where we're going to be looking when we do the Q&A session at the end of today's workshop. So please use the Q&A chat for any questions that you may have about today's presentations. And any questions that we don't get to during the live Q&A session will be answered in a Q&A document, which will be sent out following the workshop. We are recording these presentations, so hopefully those will be available for you in a few weeks on our Flossie site as well, and I'll send out an email when you're able to view the recordings of any sessions you might have missed. So that is my welcome and introduction to today. We are very happy to have you join us for this week's session. And now I'm going to turn the floor over to Georgia Yee, our Health Registry Systems Manager here at the Arizona Cancer Registry, and I'll let her share whatever else she'd like to about herself. So Georgia, you are up. Oh, and Georgia, you're muted.
Sorry, can you hear me now?
I can hear you and I can see your slides. So you should be all set.
Great, thank you. Thank you, Juliet. That's a loaded question when Juliet asked me to talk about myself. I've been with the registry for over 30 years. I know many of you, but I know we have a lot of new abstractors abstracting in Arizona. So welcome if this is your first meeting, welcome to this our annual educational workshop. It's good to see everybody virtually. You are in session 3B, and I hope to cover just an Arizona Cancer Registry overview and recent updates. Some of this information many of you have already heard, but I'm hoping to provide you updates on some projects that we're currently working on. And I'm going to take my video off for a sec, and then I'll come back on later on. Can you see that my slide has changed? I just want to make sure.
Absolutely.
Okay, great. Great, thank you. So my objectives for today's discussion is I'm going to plan to share the latest Arizona Cancer Registry updates and national updates. I'm going to talk about the latest numbers for timeliness and completeness of Arizona data and information about how we're monitoring hospital reporting. I'm going to talk a little bit about our CDC cooperative agreement and also share the latest updates from our advisory committee, as well as talk in greater detail about our 5-year cancer plan for Arizona and how cancer reporting is so intertwined with this new cancer plan. First, I'm going to start with national and state updates. So many of you are aware that the federal budget for fiscal year 2026 has not been passed by Congress. It's in the news every day. We're bombarded with this information, and you may want to think about how that impacts us. So everyone, if you don't know, we are funded through state appropriations, but we also receive a cooperative agreement through the CDC National Program of Cancer Registries. And so we are currently in this cooperative agreement. When we were awarded this agreement, it was a 5-year period. And so we are what we call in year 4 of that funding. And our fiscal year runs different than Congress's fiscal year. So our fiscal year runs June 30th, 2025 through June 29th, 2026. So we're kind of in the middle of year 4. So the fact that Congress has not passed the budget, yes, has not impacted us, as long as we're able to continue to draw down funds for year 4. So that kind of gives you an idea of the different fiscal years and the fact that we're still keeping an eye on what's happening in Congress, because when we're looking ahead to year 5 of our funding, the fact that they haven't passed this 2026 budget could potentially affect us in the future. So that's how those two things play into each other, just to give you an idea. I know that NCRA has been great at providing updates related to what's happening at the federal level. And I would encourage you to keep reading those updates. And yeah, so that gives you information of what's happening at the national level. Now going down to the state level and what's happening at the state level, we have a new interim director. Her name is Sheila Scholander. This is a person who's kind of grown up in this agency, and she's managed prevention services for a long time. And so we're looking forward to her being in this interim acting role as our director. So stay tuned, because I'm sure there'll be news related to what's happening at the state level, state budget, with Governor Hobbs and her appointees, etc. And so I wanted to share that information with you. The other big news is within our agency, there has been a movement of our registry reporting structure. And I have several slides that are going to talk about what this new structure looks like, to give you an idea. But we have new bosses that I report to. And so we're kind of, they're getting familiar with us and we're getting familiar with them. In terms of our priority right now, our registry is currently focused on our data submission that's due in November of this year. In terms of impact, what's happening at the federal level, the fact that CDC is not working right now could impact this data submission, because there are certain steps that we need to complete in order to submit our data. And so we've been unable to complete some of those steps because CDC is not in office. And so we're kind of waiting. We're still working on the submission. We're hoping to get it done and submitted in November, but everything hinges on what's happening at CDC, and how those impacts might also affect our other submission to NACER. So I'm gonna share with you our new organizational structure. So we have been moved, the way the agency is structured is they have various divisions. And we are now in the Division of Prevention Services. And our leader is Celia Nabor. Sorry, my phone is ringing. Hold on a sec. Sorry about that. I'm in the office today and I still have a desk phone and it was ringing. So our new assistant director is Celia Nabor. And the way the division is structured, then you break down further into bureaus. And in this prevention services, they have 4 bureaus. They have chronic disease and health promotion, assessment and evaluation, and that's where we're located. And I'll talk more about that bureau. They have women's and children's health. They have nutrition and physical activity and the WIC program. Okay. So I mentioned that we are now located in the Bureau of Assessment and Evaluation. Our leader is Martin Celaya, and he's what we call a bureau chief. And within this bureau, we have 4 offices. We have prevention, epidemiology, and evaluation. And that office is mostly related to surveillance on maternal and child health, opioid and overdoses, violence and injury, and chronic disease. We have the Office of Fatality Review. They encompass programs like child fatality review, maternal mortality review, sudden unexpected infant death registry, overdose fatality review, and suicide. And the Office of Population Surveys encompasses programs like Behavioral Risk Factor Surveillance System. That's what we call BRFS, and that they are the program that does random digit dialing for home surveys, and they ask questions about health behaviors. And they also have the Youth Risk Survey and other programs in that area. And we are located in the Office of Health Registries. You're familiar with that term. That name has not changed, at least for now. So this is what the cancer registry looks like. We have it broken up into 4 sections. Raeann manages the operations section. Within that section, we have Mike Raymond, Jordan Burge, and Sarah Yeager, and Paris DeAndrea. I think I'm saying that name right. She's our intern, but we basically have most of the oncology data specialists in that group. And their responsibility in operations is when we get that, they are the point of contact in terms of receiving all the information, all the case reports, all the data that comes in. They are responsible for data processing, quality control, record consolidation, data editing, tracking, onboarding new facilities, data collection from all sources, hospitals, clinics, physicians, path labs. And so they are, when you initially make contact with a registry, they're the group that you communicate mostly with, especially Raeann. Michelle leads the quality assurance section, and she is doing QA studies, audits, death clearance, which I'm sure most of you are familiar with. The audit state data exchanges. She develops our edit meta files, assists with overseeing data submissions, Um, she runs Match Pro programs. She does a lot of research QA requests, and offers also includes database software support. So I'm sure I'm not listing things on this slide that I should. Training section, Juliet manages that program. She does all the internal and external training. She documents our policies and procedures, user manuals, guides, ROI request. Also, she's managing Match Pro deduplication program that identifies our dupes in the system. She also does research QA request, and she produces our ACR newsletter. Dana Doyle is our epidemiologist, and she does all the data analyst activities, report writing. She addresses cancer concerns. She works with our human subjects research to process all those data linkages and handles all data requests and data support for the coalition. So I'm sure I'm missing things in all of their areas, but you can see that they handle a lot of activities. Okay, so we previously notified all hospitals about these rule changes. They were effective June 2nd, and my plan is to follow back to those hospitals that we identified that the rules affected. But the three major changes related to the rules are listed on this slide. Two of them are directly impact our hospitals. The first one is under C, where we basically said if a hospital with a licensed capacity of fewer than 50 inpatient beds is part of a hospital system consisting of two or more hospitals under the same governing authority as defined in ARS 36-401, the Cancer Registry or the other designee of the hospital system shall report according to subsections for patients of the hospital. And so that mostly affected what we call our rural hospitals. If they belong to a hospital system, now that hospital system is responsible for reporting those cases. And I think we sent an email a long time ago, actually identifying all those facilities that it impacted. And I've already followed up once and will be following up again soon back to those hospitals. The other one that impacts hospitals is the last one that's listed, and that's related to follow-up. So 80% of all analytic patients during the past 15 years or from the hospital's reference date, whichever is shorter. So that change was made so to be consistent with the Commission on Cancer. And it actually benefits hospitals because it's a shorter time frame in order to meet this standard. Because before it used to be the hospital's reference date, we assume that every hospital's reference date is when the rules became reportable, and that was 1992. So this actually helps out for hospitals for doing follow-up, for sure. The D section, I just included that, but that mostly impacts clinics and providers. We lowered the threshold to 50 from 100 to report electronically. And so that's the impact to clinics and physicians. Okay, follow-up. I included this slide just to kind of give you a heads up that we will most likely resume follow-up files in 2026. And we're probably going to request a couple volunteers just because we haven't done it in a while. We want to kind of test the process on your end. We want to test the process on our end to see how that's going to work. And if you want to volunteer for that testing, just put it in chat And I can't see chat right now, but we'll make note of it if we have any volunteers. Otherwise, we'll try to call or follow up in 2026 for volunteers. The other thing that I noted on here is modified records. And these are correction records. We've been asked from a lot of vendors about, are we going to require modified records? We are not currently requiring them. We know there's a lot of testing going on in various states with modified records. But the problem is that every state wants a different trigger in terms of when a correction record is sent. And so they're trying to reach, there is a committee formed to discuss this, to come up with a consensus on what a modified record looks like and what triggers a modified record. So stay tuned for this, because whatever comes out of this nationally, we may end up testing this in order to receive what we call correction records. Okay, I'm going to switch gears now and talk about the Arizona Cancer Control Plan and what it has to do related to hospital timeliness and completeness. So in my last talk last year, I touched on the Cancer Control Plan for the years 2024-2029. This is the state's 5-year strategy to fight against cancer and reduce the cancer burden. The coalition, which is the driving force behind this control plan, is a group of diverse clinical, community, and civic stakeholders. The coalition is broken out into 5 work groups. Those work groups are early detection and prevention, treatment, survivorship and quality of life, childhood cancer, treatment, and policy. So within this new cancer plan, the Arizona Cancer Registry is responsible for 2 specific objectives in the plan. And I'll talk first about this one, which is directly related to cancer reporting. This objective actually belongs in the policy work group. And our objective is the percentage of cancer cases reported on time according to regulation will increase from 27% to 75%. The strategies at the time that we developed were developing and disseminating materials on the importance of cancer reporting, signed by coalition stakeholders with the goal of informing hospital administrators. The second strategy was to develop and implement a quality improvement process that incorporates sharing of hospital cancer reporting information with the goal of encouraging more timely reporting. And the last strategy was increasing electronic cancer reporting from providers and clinics. So we want to look at the problem. And so this is looking at hospital reporting in terms of percentage of timeliness, the percentage of cases that we're reporting on time. So this is looking at submissions from January through June of this year. And the green bar represents on time. The orangey color looks at the percentage of cases reported by hospitals. So you can see from month to month, the percentage on time kind of fluctuates. The highest was 26%, the lowest was 15%. So you can see that we still have a timeliness problem from hospitals in terms of reporting according to regulation. I found this fascinating for June of 2025 because the cases received from hospitals dropped drastically. And I don't know if it's related to, because we know that some hospitals converted to different software applications. And we also know that many hospitals also converted to V25. So I don't know if that's the explanation for this drop in cases received for that month. So it's interesting. So we're going to keep an eye on this for future months. This is looking at completeness now. And you can see when we look at data, a lot of times we focus on what's required during our submission. And so we submit what we call 12-month data to CDC in November, and that is 2024 data. So that's our 12-month data. Our 24-month data is our 2023 year. So you can see month by month, the numbers are increasing, but we're not where we should be. So looking at October, for example, the 2023 data is sitting at 86.74%, and we should be 100% at this point. In terms of 2024 data, we should also be at 100%. So you can see that we not only have a timeliness problem, but we also have a completeness problem. So related to the objective that's in our current cancer plan, here's the update. We focused on developing an internal QA dashboard in order to better monitor hospital reporting. And I'm going to share some of the things that we've done related to that. We've developed infographics demonstrating the importance of cancer reporting. We've also developed a letter that it will target hospital and oncology administrators. So now that I remember this, Juliet is going to be sending a survey soon, trying to gather information. So please make sure you respond to that, because we are looking to make sure that we have the correct hospital administrator for each hospital. So look for that email from Juliet. Also, we've continued to onboard providers and clinics in order to increase electronic reporting. Okay, I'm going to talk about the QA dashboard and what some of the reports that we're producing from this look like. So do you all remember these previous reports that we distributed? These were reports that were created by Keith, where we provided them to you on a quarterly basis. It looked at completeness, it looked at timeliness, and it looked at your actually submissions in this lower area. So this is what the previous report looked at, and this is what the report looks like now. So this is what we're calling the new facility level report. And I'm going to break it down by sections, but at the top here, this will be the date we produced it. We'll identify your facility. We'll put the 3-digit ID as well as the name of your facility here. The diagnosis years that are currently on this report. We'll put the actual number of cases that you submitted for this report, as well as expected, and we'll identify missing cases, what we perceive as missing, and we'll document on time percentage versus late. So that's the first banner. On here, this left-hand side is looking at completeness. The right side is looking at timeliness. Okay, and we're gonna go into these two sections in at a later slide. In addition to the facility level report, we will also produce what we're calling a new hospital group report. And that is in order, because we have so many hospitals that are part of a system, we will produce a total group report. Like, for example, Banner has many hospitals throughout Arizona. So we'll produce one group report that summarizes all the submissions for all of Banner, for example. And we'll have the same information on this top bar. And we'll break it down here. What's on the left side of the screen, or the left side of that report, focuses on completeness. These are the tables that produce this information on the graph. And it's very similar to our previous report. So we're documenting diagnosis year here, the number of analytic cases that were reported, the number of non-analytics cases here, and the total counts here. And then on this side, it's again the diagnosis year, the expected number of cases. And again, this is a 2-year average in terms of how we project the expected. And then the difference basically of the total versus what's expected, and that's the difference, and the percent here. And this is showing it in graph form. And I think this yellow line graph here, is telling, because in a snapshot I can see, are the hospitals meeting that target? So very useful information about each hospital. So this is the right side of the report, looking at timeliness. Again, this graph or this table provides the information that produces this graph on top. This is the year submitted. This is the cases that reported less than or equal to 12 months, greater than 1 year, greater than 1.5 years, greater than 2 years, and the percentage on time. I think we've actually updated this graph because we actually moved on time to show first. So when you do get these reports, there's going to be some movement of some of these parameters. And as you can see, it graphs the information on top. Okay. Okay. So remember I mentioned we were going to do several things to improve reporting in addition to distributing the previous reports that I just showed you. We have created, or Dana has created, infographics. And we have what we call a data version and a narrative version. And what you see on the right-hand side is the data version of the infographic. And in terms of information, again, the header here is improving cancer reporting, how Arizona hospitals measure up, and explains what this infographic is. In the importance of hospital reporting, hospitals provide 86% of registry data. Timeliness starts here, so that's an important big number here. 1 in 6 cases reported on time, and it explains it here. If you go to this side, it talks about the patient's journey from the patient visit to hospital registrar abstracting the case, and it shows the journey on this side. And then going back on this side, when our case is reported, really reported, it kind of shows breakdown, the percentage on or the number of cases on time, late, greater than 1.5 years, very late, up to 2 years, extremely late, over 2 years. So that pretty much provides the important information. And this is what we're sharing with the hospital administrators in terms of the importance of cancer reporting. Let's see. Okay, so this one is the narrative version. And again, it's kind of repeating the same stuff, but it's saying it in a narrative fashion. How timely reporting starts with you. Cancer reporting has been required by law since 1988. Oh, I think we need to switch that. I just noticed that. So Dana, we need to switch that year. Timely reporting, it talks about timely reporting and how data is used, who uses it, obviously for research, national cancer trends, public data requests, program planning. So the importance of driving the message home that cancer reporting is important, especially when we talk about timeliness and completeness of reporting. Okay. So one of the things that we're required to do for our CDC grant is to write a success story. And actually, our collaboration with the coalition and the policy work group is in building this partnership and really emphasize cancer reporting is kind of one of our top priorities. It's so far has been successful. So Dana wrote about our experience, and we were happy to see that it was published in the summer issue of the Journal of Registry Management. And so if you haven't looked at it, please look at it. It's, like I said, it's accessible. It's in the Journal of Registry Management. So please visit that, that edition. Okay. The third strategy, if you recall, related to the cancer plan was increasing electronic reporting. And so we have embarked on a mission to increase our clinics and physicians to report electronically. And we're actually using WebPlus also to onboard them to report it electronically. And we've been very successful. So we notified dermatologists and other providers of the rule changes back in April. And we also wrote about it in our newsletter that's distributed to many dermatology offices throughout Arizona back in July. And Raeann's had several lunch and learn sessions to train clinics and providers how to report through WebPlus. And one of the things that we do is we track from year to year the percentage increase in terms of electronic reporting from our providers and physicians. And so you can see it's been a steady increase. Our numbers are low, but it has been a steady increase. We currently have a total of 17 clinics reporting currently through WebPlus. You may think that number is low, but we have several clinics that have several providers reporting under their umbrellas. So that is a total, those 17 clinics are 151 providers. And so that is very important to us. And what we have, the group that we have targeted are dermatologists. And so we get most of the melanoma cases reported still through paper, but we're slowly transitioning them to this WebPlus reporting. So that's great. So kudos to Raeann and the ops team for doing this work. Okay, and so in terms of hospital reporting, because I get asked this question frequently, those monthly progress reports will continue into the future. What that looks like, it most likely will change. Right now, Many of you send emails to me reporting progress, but most likely the format is going to change in the future. And just kind of a reminder for those hospitals that have to do those monthly progress reports, we're looking at consistent progress toward meeting regulations. We may request an update to your plan with new timeframes and estimates, but those monthly progress reports should include details about how your facility is on track to meet the deadline according to regulation. If you have barriers to reporting, what your facility is doing to overcome those barriers. The month and year abstracting, that's very important to me because I do some comparisons with what's actually coming in. And if I have an issue, I may question you about that. If you're in need of resources and you've identified that as a barrier, or if you've added staff, that's important to share. And any plan changes that you foresee coming that will impact cancer reporting for your facility, I want to know about that. And I've already mentioned that the format to these monthly progress reports may change. Okay, continuation regarding hospital reporting. The dashboard that we're currently working on that produced those reports that I just shared with you, we're going to continue to build and monitor performance through this dashboard. We're probably going to add data items that monitor the quality of the information coming in. I'll give you an example like race. We want to know how complete the data is that you're submitting. So those are kind of indicators that we're going to use to monitor quality, and eventually we'll use those quality indicators that we develop to produce reports that will go back to you. So we're building a system that hopefully provides feedback back to you. We're also looking at, we want to acknowledge hospitals that are doing really good at reporting. And so we're kind of tossing around what that looks like, whether it be a certification or some kind of acknowledgement. So that's kind of what we're looking toward. But we also want transparency. And what I mean by that is we would love to post specific hospital information on our website, whether we have to get approval from our leadership, but that's what I mean by transparency. We want to show and share information about every unique hospital on our website. Yeah. And we do something very similar where we, with our dermatology offices as an example, we produce a list of every dermatologist that has reported and the number of cases they have reported to us. And we distribute that once a year to all the dermatologists that are on our email distribution list. And what we have found is dermatologists really love that report because to them it verifies that yes, they're sending cases, and yes, they sent all the cases that they should have. If that number is lower than they expected, then they contact us and they want to do kind of a mini audit where we show them the cases they reported and they look back at their listing and we compare, and it's helped them and us because we've identified cases that they thought they submitted to us, but they didn't. So it's been a kind of a win-win situation. And so we'd like to do not that exact thing, but something very similar with hospital reporting. Okay. So many of you have heard me talk about the melanoma task force. And for those of you who don't know, this group serves as our advisory committee. We meet bi-monthly, and the members are listed there on your screen. So it's a very diverse group. And initially, the task force was created because we identified an issue with underreporting of melanoma cases. And that group turned melanoma reporting around for us, for sure, because we have many dermatologists on the group, and those dermatologists helped us to educate other dermatologists throughout the state. And so it's been a very helpful task force to work with. They continue to work with us to increase reporting, and also work with us in terms of electronic reporting. We also produce a yearly newsletter with reports, and like that listing I just described, we attach that to the newsletter. They are involved in an Arizona-specific melanoma objective, and I'm going to share that in the next slide. So this task force is directly involved with this objective, and that objective is to decrease the percentage of late-stage melanomas diagnosed in Arizona by 5%. And the first strategy was to establish a baseline to measure late stage, and we have done that. So our late stage percentage currently is at 5%. The next thing we're working on is we're updating the Arizona melanoma profile. And that will include additional demographic information to inform evidence-based interventions. And we have started that work through the task force. We have outlined what we want to include in that profile, and we've assigned task members to certain sections of that profile. And so we're kind of in the middle of it. Our goal is to get this profile done by, I think, June of 2026, and Dana can correct me if I'm wrong, but that's our plan. The last strategy we haven't touched yet, but mostly this is going to be driven by our partners on the task force, because this is an area that it's not our expertise, and we're hoping the dermatologists and the universities can help us to increase educational outreach on early detection of melanoma in at-risk populations. And so that is an objective that is written into the cancer plan currently. These new two next slides are related to what we traditionally include in a melanoma newsletter. And you can see that this graph shows 2018 through 2022 data, and we break it down by invasive, which is the green color, and versus in situ, which is the purple color. And you can see that each year we've kind of increased reporting for melanoma. For 2022, I can't believe that we currently have over 7,000 cases reported for 2022. And for 2023, we expect as many cases. And you can see that this task force has definitely helped us to improve melanoma reporting. And so much so that it is now the 4th most common cancer in Arizona. So this is comparing Arizona to the US, and this is looking at invasive melanoma age-adjusted incidence rates by diagnosis year. And you can see the brownish color is Arizona incidence, the yellow color is the US incidence. And you can see, looking at 2022 data, for every year actually, Arizona definitely has higher rates than the US. So the question we keep asking ourselves, is this because we do better reporting than any other state in the US, or do we really have higher rates in Arizona related to melanoma? So that's the question, the outstanding question, that will be continued to be asked over and over again, because everybody has an interest in melanoma, because we're Arizona, and with the sun, so we're constantly being asked about melanoma specifically. Okay, so I wanted to share with you our last 3 submissions for NACER, because we all know they look that our data, they are the group that certifies registries, and the first column looks at the criteria that they look at, which is like for case completeness, for example. This column here is looking at gold. This is looking at silver, what in order to meet that standard. These last 3 years are looking at our data submissions from 2020, 2021, and 2022. And you can kind of see where we fall in. This case completeness, this last year, in case you're wondering, we actually met gold, but they look at certification completeness 3 different methods. They call one method an internal method, one an external, and one is the NACER method. This 94.2 is a NACER method, but because we reached above 95% in one of the other 2 methods, they consider us gold. So this is where your data becomes extremely important, because if we don't have your cases, we can't include them. And this is how it impacts us in the big picture of things. It impacts our completeness. So if we go on, we look at completeness of age, sex, race, and county. You can see how well we do here. We have identified that it's getting harder and harder to collect race information. So if you're not getting this information reported in the chart, please share that information with us, because we've stressed nationally that it's not just an Arizona problem, it's a US problem, that that we're not getting that information. Death certificate only cases, you see that we've made big improvements in that process, thanks to Michelle and the work that Michelle and Dana has done in terms of linkages, and Michelle doing her magic related to death clearance. So we're in the gold, and it actually looks good for 2023 right now. I think Michelle told me that we were around 1%, which is great. And then, of course, these other criteria: passing edits, timeliness of cases, and certification. If a state were to get, for example, silver in any of these components, then that end result would be a silver. But we've been fortunate for the last 3 years to maintain gold status. Yay! So I'm going to end talking about this slide with training. We are doing what we can in order to provide you continuing education credits to maintain your certification. We have purchased the NACER webinar series in Phoenix and in Tucson. For Tucson, TMC is managing that series. So I'm glad that we're continuing to be able to provide you this as an option to in order for you to receive CEs. The other thing that Juliet mentioned is because of this new requirement about in-person credits. So what we are going to do to help you earn those is we will have an in-person opportunity on December 3rd on a Wednesday, and the topic is esophagus. We're going to open that up to in-person in our building for you to come in and earn those credits. And look for an email from Juliet, because she will notify you about this and signing up. We don't know, we're curious to see how many people sign up and if we have a room that's big enough. And so that's the other challenge. For your Tucson folks, know that TMC is going to have a room available. We're applying for credits for that specific webinar in Tucson also. So for the Tucson area folks, you will have the opportunity also to go to TMC and earn this credit. And so when Juliet provides the information for the Phoenix site, she will also provide the information for the Tucson site. At least I think she is. Yeah. So, so we're looking to present probably another in-person next year also. So know that this is not just a one-time event. We're kind of looking to continue this every year so that we have the opportunity to earn these in-person credits. And that's all I have. Thank you for your time and attention. Thank you.
Thank you so much, Georgia. A lot of good information in those slides. And with that, we have our next presenter, and that will be our epidemiologist, Dana Doyle, talking to us about the current state of cancer in Arizona. So Dana, whenever you are ready, you are good to go.
Great. Hello, everyone. I'm Dana Doyle, like Juliet said. I'm the epidemiologist for the registry. So today, my presentation, I just want to give everyone an update on the latest statistics for Arizona. We're going to be going over cancer incidence and mortality rates, and then looking at our top 5 cancer sites. And at the end, I will go over just some examples of how our cancer registry data is being used to promote public health. And we will do a dashboard demo to kind of show you some resources of how you can look at cancer statistics on your own. So I am going to also turn off my camera just for this presentation, since you'll just be looking at the other half of my head. So I will pop back on afterwards. And if you have any questions, just put them in the Q&A chat box, and we will do that in the formal Q&A session. Okay. So, like I said, we're going to be talking about some cancer statistics. So I just wanted to give some reminders on these next couple slides of how we're interpreting this data. So with our cancer registry data, we do know that COVID-19 did impact cancer reporting across the US and in Arizona. So when we look at our rates, we want to pay attention to the diagnosis years 2020 and 2021, because we do see that our case counts are lower than we would expect, but they are starting to bounce back up to pre-pandemic numbers for 2022. So when you just take a look, just keep that in mind as we're looking at this data of, were people really being diagnosed less with cancer, or was that just due to the COVID-19 pandemic? And then just some vocab, incidence refers to the number of new cancer cases, mortality refers to cancer deaths, and stage of diagnosis, which I'm sure this audience is very familiar with. It's how advanced was the cancer at the time of diagnosis. And all of the data in this presentation is the latest that we have available that is complete. So for instance, we're going to be focusing on the past 5 years of 2018 to 2022. And for mortality, we're going to be looking at data for 2019 to 2023. And then just some other points to put out there is that some of the statistics that we're going to be looking at. So we're going to be looking at counts and averages, but we're also going to be looking at age-specific rates versus age-adjusted rates. And so I just think it's really important to point these out so we all understand what we're looking at. So an age-specific rate, that tells us how common cancer is within a specific age group of people. And this can tell us, help us understand which age groups are being affected the most by cancer. And this is really important for targeting prevention, screening, and treatment efforts. And so this is pretty straightforward. And you can see with the example that if you want to look at the cancer rate for people ages 45 to 54 and see if it's higher than those as ages 25 to 34, you would use an age-specific rate to do that because it just focuses on one age range at a time. And the most common way that you'll see cancer statistics displayed is with age-adjusted rates. So that is a bit different. So an age-adjusted rate is a way to compare how common cancer is between different groups of people, even if those groups have different age distributions. And that is important to understand because older people are more likely to be diagnosed with cancer. So if we're comparing two different communities and one community has more older people than another, it might look like they have more cancer just because of age. And age adjusting levels the playing field so we can make fair comparisons by taking age differences out of the equation. And another example of how this is different from an age-specific rate is if you want to compare cancer rates between Arizona and Florida has more older adults. Age adjustment makes sure you're not just seeing more cancer because the people are older. So hope that makes sense for everyone as we continue into these next couple slides. Right, so we are going to be talking first about cancer mortality in our whole state of Arizona. And we're going to be looking at it by diagnosis year and sex. And just a reminder that for mortality, we're looking at 2019 to 2023 as our years. So in these 5 years, we experienced 132 cancer deaths occurring per 100,000 Arizonans. The rate of cancer looking at 2019 to 2023 decreased 7%. And we did see that males overall have higher cancer mortality rates compared to females, but both sexes are showing a steady decline. And with cancer in Arizona, it is our second leading cause of death, and it is also the second leading cause of death nationally. Arizona's cancer mortality rate is almost 9% lower than the national average. And looking at our top 5 cancer mortality sites for 2019 to 2023, the first is lung and bronchus cancer, followed by colorectal, pancreatic, female breast, and prostate cancer. All right, and moving on to looking at cancer mortality by county and race for those 5 years. So looking at county, we do see that our top 3 for cancer mortality is La Paz County, Mojave County, and Greenlee County in Arizona. And the counties with the lowest cancer mortality rates are Santa Cruz and Yuma County. And on the right side, we're going to be looking at age-adjusted rates by race ethnicity. And we do see that Black and African Americans experience consistently higher cancer mortality rates, and that is followed by white non-Hispanic Arizonans, and Asian and Pacific Islander Arizonans have the lowest cancer mortality rates in Arizona. Right, so now we're going to be looking at our statewide cancer incidence rate. So this is new cancer diagnoses in Arizona, and we're looking at data for 2018 to 2022. So within these last 5 years, we did see on average, 395 invasive cancer cases diagnosed per 100,000 Arizonans. And this rate has decreased approximately 6% of going from 2018 to 2022. And once again, along with mortality, males have higher cancer incidence rates compared to females. And I wanted to point out how we talked about in that first slide, the impact of COVID-19. And you can see that in the drop of the cancer incidence rates from 2019 to 2020. And we saw approximately an 8% decrease in the rate of invasive cancer between those years. And we can contribute that to the COVID-19 pandemic. And you can see going from 2020 to 22, it's slightly lower than 2019, but we're starting to climb back up to pre-pandemic numbers in 2022. And our top 5 cancer incidence sites for the past 5 years. Number 1 is female breast, followed by lung and bronchus, prostate, melanoma, and colorectal cancer. Just going over county and race once again, but for incidence. So La Paz County and Mojave County not only have the highest mortality rates, but they also have the highest incidence rates in Arizona. And another county with a higher incidence rate is Yavapai County. Looking at race ethnicity, we did see with mortality that Black and African Americans have the highest mortality rates. But when we look at incidence, we do see that white non-Hispanic Arizonans are being diagnosed with cancer at higher rates than any other group. Okay, so now that we've kind of gone over our general state cancer incidence and mortality rates, we're going to be focusing now on our 5 top cancer sites. So that's going to be female breast, lung and bronchus, prostate, melanoma, and colorectal cancer. And so the information on each slide is going to look the same. So I'm just going to do an overview, so it might be just a bit repetitive. So this first one we're going to look at is female breast cancer, which is the most common cancer diagnosis in Arizona. And if we look at that top left graph, that is going to look at our cancer incidence and mortality rates by year. And we do see that our incidence and mortality remain pretty steady, but we do see that impact of COVID-19 between 2019 and 2020 in that incidence rate. And that is almost a 10.5% decrease in cancer incidence for female breast cancer between 2019 and 2020. And moving on to the right side of that upper right corner, it's looking at female breast cancer incidence and mortality rates by race ethnicity. And we do see that once again, white non-Hispanic individuals are being diagnosed with female breast cancer at higher rates. But then Black and African American women are dying at higher rates of female breast cancer. In the bottom left, we're looking at stage of diagnosis. And for stage of diagnosis for this presentation, we group it into 3 categories of early stage, which is our in situ and localized cancers, late stage, which is our regional and distance, and unknown is when we did not receive any information for stage of diagnosis. And for female breast cancer, I'm happy to say that majority of our cases are being diagnosed in early stages at 71% of our cases in the past 5 years, which is great and proof that our screening does work. And in the bottom right, I have age-specific rates for female breast cancer. So this one's again just looking at comparing those age groups. And so we do see that the older we get, the more likely individuals are to be diagnosed with female breast cancer. And the age group with the highest rates is those ages 70 to 74, at 444 cases per 100,000. Okay, so moving on to our second site, which is lung cancer, lung and bronchus. So same formats, we're gonna go look at that upper left graph, looking at rates by year. And we did see that going from 2018 to 2022, a 19% decrease in incidence, and also an 18% decrease in deaths. So this is really great to see that we are seeing decreases in our incidence and mortality. And it doesn't look like the COVID-19 pandemic had a super big impact on our incidence and our incidence and mortality rates. Looking at it by race ethnicity, we do see a very similar trend that white non-Hispanics are being diagnosed at higher rates, but Black and African Americans are dying at higher rates of cancer. And stage of diagnosis, this is one where unfortunately we do see majority of our cases being diagnosed in later stages when the cancer has advanced. And for the past 5 years, we saw approximately 60% of our lung and bronchus cases being diagnosed late stage. And then looking at age specific rates by sex. So for this one, I wanted to demonstrate how cancer is increasing as we get older, but if there is any differences when we look at it between male and female. And so this one is very interesting because in those, it's hard to kind of see it in this graph, but in those younger years, ages 40 to 60, we do see that females have higher rates of lung and bronchus cancer, but after those in ages 60 and older, that flips to males having higher rates of cancer. Okay, moving on to prostate. So prostate cancer incidence. So this is one where we do see that a big drop between 2019 and 2020 with that COVID-19 year. And we did see a 15% decrease between 2019 and 2020 for the incidence of prostate cancer. And looking at race ethnicity, this is one where it kind of breaks from our trend of seeing white non-Hispanics being diagnosed at higher rates and Black and African Americans dying at higher rates. For prostate cancer, we do see that Black and African American men are highly burdened by this cancer, with 120 cases diagnosed per 100,000 Black and African American men, and they also have the highest cancer mortality rates for this cancer than any other group. And with stage at diagnosis, we do see that majority of our cases are being diagnosed early stage, which is great at 64% of our cases. And then for age-specific rates, we do see that the highest age group for a prostate cancer diagnosis is those, once again, ages 70 to 74 years old, with 483 cases per 100,000 people within that age group. Melanoma, so we have 2 more cancer sites. And so I know Georgia just talked about a lot about melanoma in her presentation in the melanoma task force, but our melanoma rates, for instance, have increased since 2018 to 2022 at about a 9% increase. So that is something, you know, we always think about, is because we're seeing more melanoma or because we're getting better at reporting. And our mortality has remained steady from 2018 to 2023 at 2 deaths per 100,000 Arizonans. Looking at race ethnicity, I did see that part of mine got a little cut off, but white non-Hispanic individuals in Arizona have the highest burden of melanoma in regards to incidence and mortality. And for stage of diagnosis, this is one where we see the vast majority of our cases being diagnosed early stage at 94% of our cases, which is really, really great. And then looking at age-specific rates by sex, this is another one that is pretty interesting where we see in those younger age groups, and this time it's 20 to 44 years old, that females have higher cancer incidence rates. And then afterwards, males surpass females with cancer incidence for melanoma. All right, and our last, colorectal. So for colorectal cancer, we do see that this is more steady over time with not too much fluctuation in our cancer incidence rates or cancer mortality. And we did see approximately a 6% decrease in the rate of colorectal cancer. And looking at mortality, incidence mortality by race ethnicity, we do see less differences between race ethnicities in regards to incidence, but white non-Hispanics still have the highest cancer incidence, and Black and African Americans experience higher cancer mortality rates for colorectal cancer. And for stage of diagnosis, unfortunately, we do see majority of our cases being diagnosed in late stage, despite national efforts to increase colorectal screening accessibility. So we still have 59% of our colorectal cancer cases in late stage. Once again, looking at age-specific rates by sex, we do see that males have consistently higher colorectal cancer rates by age group, but when we get to ages 80 to 84, we see that switch where females have higher cancer incidence rates for colorectal cancer. Right. And then I just wanted to include some information on 5-year relative survival, and I included those cancer sites that we just talked about and a couple others that are in our Arizona Cancer Control Plan. And so 5-year relative survival is the percentage of people with cancer who are expected to be alive at least 5 years after their diagnosis, compared to people without cancer of the same age and background in the general population. So we can see for that, for all cancer sites combined, that the differences between a male and female, that females have a 69% 5-year relative survival compared to males with 63%. And across these cancer sites, we do see that females ultimately have a better 5-year survival compared to males. Okay, so that is the end of our very data-heavy slide. So thank you for bearing with me. I know that can be a bit repetitive. So now I wanted to talk about how our cancer registry data is being used. So all the work that everyone on this call is doing, how is it being shared with the public? And so I can group this into 4 main categories. And so the first one is research and data requests. So we get a bunch of requests from the public universities within ADHS and the counties wanting to use cancer registry data for their research. And these are research studies that have to go through our Arizona Department of Health Services Human Subjects Review Board and gain approval. So they have to go through a whole process to show how this data is going to be used, how it's going to be protected, and then how it may be shared. And within this group is our virtual pooled registry, which I will talk about more later on because it's a favorite of mine. But it is something that NACER put together to serve as a one-stop shop for cancer research and data linkages. And then other ways our data is being used is for data dashboards and annual publications. You saw a little bit about that in George's presentation with the Melanoma Task Force, some of the publications that we're doing with the Cancer Coalition and our dashboard that I'll be demonstrating at the end of this presentation, as well as our QA dashboard. So with our data dashboard and all of our publications, you can look at aggregate cancer counts and age-adjusted rates by year, cancer type, sex, age group, and race, ethnicity, and county. And unfortunately, mortality data is not currently available on our data dashboard, but I can provide resources where that information is available. And then we also respond to cancer concerns in the community. And this is a process that we have been refining since I started with the agency. But this is when Arizona residents report to the cancer registry that they're concerned about cancer where they live. And we can take a look at our data and tell them on a lower geographic area than county how common cancer is or the frequency of cancer. And then lastly, we do a lot of data linkages and data exchanges. So we do linkages with our CDC-funded breast and cervical cancer early detection programs, Indian Health Services, and VA facilities to collect cancer data. And we do other data linkages to improve the quality of our data with our hospital discharge data, our vital records data, and then also the National Death Index and Social Security Death Index for accurate death information. And this is just an example of all the different sites where we can see our Arizona Cancer Registry data being displayed. And so this is our data dashboard, the NACER data dashboard. Some of our older infographics have been recently updated. The CDC data visualization, cancer statistics, a tool, CDC Wonder, NCI state cancer profiles. We have the public health tracking network, and then also our data was used in the Navajo Epidemiology Center and a report looking at cancer among the Navajo. So then I'm just going to touch on each of these briefly and just kind of give you some background information about what goes into these requests. So for a data request, we can receive an aggregate request. So this can be from universities, hospital systems such as yourselves looking kind of for feedback and to get a temperature check of where you guys are at with your reporting, ADHS programs, and community organizations. And this is when people are really just interested in some more basic information of looking at what we call descriptive statistics, which is our averages, our median counts, our percentages, and or age-adjusted rates on a state or county level. And anyone can request this, and I always refer people to look at our data dashboard and our publications, and if you can't find what you're looking for on there, you can reach out to me and I can help you. And some examples of aggregate requests that we have received. We received one from the Mayo Clinic that was interested in age-adjusted incidence rates for gallbladder cancer for non-Hispanic white and American Indian Alaska Native Arizonans by sex. We received one from Tufts University looking for age-adjusted rates for early onset invasive colorectal cancer for Arizonans by county. And also from the Yuma Regional Medical Center, which wanted the average time and days from diagnosis to treatment for breast and lung cancer cases diagnosed in Arizona by county. So this is definitely information that's not readily available on our website. So people will come to me and we can kind of get a more detailed look for their request. Human Subjects Review Board, I just kind of wanted to give some background information of the process that these researchers have to go through, and also our registry staff have to go through in order to have data be released. And so the Human Subjects Review Board is a committee within HHS consisting of epidemiologists, lawyers, and data analysts that review each request that comes in. And researchers are required to look at their application, confidentiality agreements, security checklists, the data items being requested, their resumes, protocols, and previous IRB review approvals. And the researchers contact the registry prior to any HSRB submission to determine whether the registry has the ability to fulfill the request and provide guidance on what is available to be requested. Because I'm sure, as all of you know, our data items change frequently, and to the public who are not oncology data specialists or not registry staff have sometimes a difficult time navigating those data items and how they have changed over time. So we work with them to make sure that we are only sharing what has been required to collect to ensure the accuracy and completeness of the data that's being shared. And our cases that we release are only cases diagnosed 1995 and forward. And we do not release cases that are solely reported by VA and military facilities or out-of-state registries. So I did mention the virtual pooled registry. So this is a favorite of mine because I think that it is a great system to increase the efficiency of data sharing and having researchers being able to access cancer registry data for their work. So this is put on by NACER, the North American Association of Central Cancer Registries, and they call it a one-stop shop for cancer data linkages. So registries are selected to participate in studies based on the number of matches with their study cohort file. So what this means is that each registry, we prepare a file for our virtual pooled registry for linkages throughout the whole next year, and that is created using our call for data file. So when our data is the cleanest it can be, it's ready to be submitted, that is the file that we use for our linkages. And then these researchers have a specific cohort of patients that they are following and they want to link with our cancer registry data. So this process has created really standardized forms and applications, configuration files to be able to perform these linkages so that they are uniform and they are succinct and that they're really easy for people to do. So like I said, what makes this process great is clear instructions, standardized applications. We have standardized VPR data use agreements, and researchers kind of prepare their own files themselves, and it has to meet certain criteria to be able to link so that we know that they have high quality data. And the registry actually facilitates the HSRB process for researchers. And so what this is really great and kind of what makes standardization so great is that when these researchers wanted to perform these national studies and link with multiple registries at one point, they would have to go through each individual's registry's version of an HSRB, fill out their own unique application, do their own unique data use agreement, and that can take up for years to complete. So this process is able to kind of remove that kind of stressor and just be able to send one application to multiple registries at once. So and hopefully everyone can see the value in that and why it is so great in regards to being able to share accurate and timely data. And just this is a text heavy slide, but just some really interesting VPR studies that we have participated in. And we have participated in over 14 VPR studies, at least since I've started with the registry. So the first one is the sister study. So this is comparing women who have been diagnosed with breast cancer and if they have a sister who is not diagnosed with breast cancer, and they follow those women over time. And the community-based cohort study of disease incidence in Ohio and West Virginia. This is a really cool study looking at PFOAs, those forever chemicals that were admitted into the water when the manufacturing of Teflon by DuPont and its West Virginia plant. So it's doing a linkage with residents in those areas that may have been exposed and following them over time. And also the study on the incidence of cancer diagnosis and mortality among military aviators and aviation support personnel. So this was one that was actually requested by Congress to look at our military aviators and the fumes that they're being exposed to and if they are experiencing higher cancer diagnosis rates in that population. And then lastly, I have the cancer incidence in the Strong Heart study and the Strong Heart family study. And so this was looking at incidence rates of all-cause and obesity-related cancers among American Indian populations. And we are able to use our data to kind of assist that cohort and study that population that is so present in Arizona. And lastly, I just have, I think, one or two slides on cancer concerns, because a cancer concern, like I said, is when a member of the public reports to the registry that they're concerned about cancer in their community and that there may be something causing people to get cancer. And in 2022, the CDC redefined the definition of a cancer cluster. And so you can read that, but it's looking at very specific groups of people on a specific time period and looking at how cancer has impacted that community. And I just want to point out that these cancer clusters are very rare. In the American Cancer Society, they have put this statement out that one review of 576 cancer cluster investigations conducted over 20 years found that for only 72 of the apparent clusters could an increase in cancer rate be confirmed. Only 3 of the 72 clusters could be linked to a potential exposure. And in just one case was a clear cause identified. So we use this work and we try to share with the community about how common cancer is, but we're not able to identify the cause of cancer with our data. So we're working on redefining this process to be helpful and informative to the public. All right, and so the last bit of my presentation is going to be talking about our data dashboard, and I'm going to be doing a data dashboard demonstration. And so with our data dashboard, it was updated last December, and we update it after we submit our data for our data submission at the end of each year. So right now it has cancer incidence information for diagnosis years 1995 to 2022. And we only have incidence data available, but we're hoping to add stage of diagnosis and mortality in the future. On this site, you can look at counts and age-adjusted rates by diagnosis year, primary site, sex, race, ethnicity, and county. And we also have age specific rates for 5-year age groups by cancer site. And just a general rule for our data dashboard is that we suppress 10 cases or less. So if the case count is under 10, you'll see a little asterisk because we do not produce that rate because it could be unreliable. So let me see if I can pull up the data dashboard, and I'm just going to need someone to confirm whether or not they can see my screen of the dashboard because I haven't really done this on Zoom.
We can see
I
it, Dana.
can see it.
Perfect. Thank you. So I'll zoom in really quick. So this is our cancer registry data dashboard if you aren't familiar with it. And so this is our main overview tab. So right here you can see when the data was last updated. And like I said, that was last year. And if you go over here to the I information, it will tell you everything you need to know to interpret the data on this page. And then also our contact information if you have any questions. So when looking at this page, we can customize what we're looking at. Up here, we have our diagnosis year selection, and it's defaulted to all diagnosis years. You can see that we have 1995 through 2022 available. And you can select individual diagnosis years if you are interested in that. And if you hold down the control bar, you can select multiple diagnosis years as well. So I'm just going to select those. And once you click that up, this will carry over to all tabs on the data dashboard, which is really great. So you don't have to keep reselecting. And you can also make it specific to sex. So, excuse me. So if you want to look at male or female or look at both sexes combined, you can choose that there. For the purpose of this, I'm going to look at both male and female. And we have a lot of really interesting information. So we have our age adjusted rate over here. We have our case count for that time period and the median age of diagnosis. We also show our trend line. And so you can hover over these points and see for that year, the number of cases and the incidence rate. And below that, you can see our top 10 cancer sites. And those are ranked below, and they're ranked by the age adjusted rate. And if you hover over, you can see the case count and rate. And if you want to see for female breast cancer, you want to see all this information, but only for female breast cancer, you can just select that and it will change everything on the slide. I'm sorry, not the slide, on the dashboard. So same thing for prostate. And if you want to go back to normal, you just click it again and it goes back to all cancer sites combined. And we can also sort, instead of by the rate, you can do it alphabetically as well. And just some more information on how that's interpreted and how those cancer sites are grouped. So that is the overview tab. And then we're going to go into our details dashboard. So once again, you can see those diagnosis years carried over, so we don't have to reselect. And this is where you can find counts and age-adjusted rates for each cancer site. So this is a pretty comprehensive list of our cancer sites. And you can scroll through that. And if you want to sort these to find the cancer site with the highest age-adjusted rate, you just click here. And you can see female breast, prostate, lung and bronchus colorectal. And if you want to sort by the case count, you can do that as well. And also if you want to sort alphabetically by the cancer site. So that's a pretty straightforward tab. Once again, this changes for each tab to be the most relevant for what is on the page. Okay, and bring it to age details, once again carried over. And this is our tab for all cancer sites. And this is where we'll see on the left side where labels are important. So these are age-specific rates. So just looking at the cancer rate within that age group of people. And you can see that all down here in those red bars. And if you hover over, you can see the number of cases and the rate. And then on the right side, we can see for all cancer sites the age-adjusted rates by sex. And when you hover over, you can see that. But let's say you wanted this information for specific cancer sites. You would just go over to this individual cancer site tab, and it breaks it out into this table. So you can see the cancer site, the age groups, case count, and age-specific rate. And that is for all the cancer sites that are included on that details dashboard tab. And this is where you'll see our age suppression kick in of if it's less than 10 cases, we do not show that rate. And then once again over here, it's very similar, but we have it broken down by sex for each cancer site and looking at the case counts and age-adjusted rate. And you can sort this however you would like, and like the other pages. Okay, so going into race details. So again, diagnosis years carried over, and over here we have a more general look at our race ethnicity groups. We have white non-Hispanic, Black, white Hispanic, American Indian, Alaska Native, and Asian Pacific Islander. And we also note how many of our cases have missing or unknown race information. And on the other side, we have this broken down by cancer site with the case counts and age-adjusted rate. But what I think is really great about this page is how we're able to sort this information, because this can be a lot to look at. So if you're just interested in looking at American Indian and Alaska Native cases, you can select this bar and it will only display American Indian and Alaska Native cases in this table. And you can then sort how you would like and find the best information. So let's say you want to take it a step further and you want to look at American Indian and Alaska Native cases by sex. It will break those out as well, and you can see that this is still highlighted. And you can do this for county as well. But the further, the deeper you dive, the more likely you are to see some suppression. So just keep that in mind. And lastly is our county details page. So we have cancer incidence data available for each county by diagnosis year. So over here, you can compare it to our statewide rates. But this map is how you're going to navigate this page. So if you're interested, right now we have all of our counties selected, but if you're interested in just one county, like Coconino, you can select that and it will change all the information on the page. I'm just going to go back to multiple counties, because over here you can see the top 10 cancer sites by county for that county. And then you can break it in to our more detailed look at all of the cancer sites and where they rank for that county. Going down below, just more some county specific information, looking at all cancer sites by sex, by race, ethnicity, and then looking at those individual cancer sites and creating those tables. And all of these can be sorted the same way, and it will tell you how many cases we have missing or unknown county information. So that is kind of the main overview of our dashboard. This one is just where you can see more notes about how our data is collected, how complete it is, our COVID-19 statement, and any other information that you might need to help interpret this data. So that's my data dashboard demonstration. And if you have any questions, please feel free to reach out to me. I'm happy to help in any way. And I also included in this presentation links to all of the sites where Arizona Cancer Registry data is being displayed. So you can see all these different sources and navigate them and compare and contrast and pick your favorite. I'm very biased, but I think our data dashboard is really great. So yeah, that is the end of my presentation, and I'll pop back on my camera So yeah, if anyone has any questions or comments, we'll be answering them during the formal Q&A session, and you have my email right here, and just reach out and I'm happy to help. So I will pass it over back to Juliet.
Thank you so much, Dana, and thank you for making all the statistics understandable. I know I appreciate it when someone has that ability to make all of that clear. So great work. And next, we are going to turn things over to our operations manager, Raeann Robinson, and her presentation about what's going on with the operations team. So Raeann, whenever you are ready, you can go ahead and share your screen, and we will get started with the last presentation of the day.
Okay, can you see my screen?
Looking good.
Okay. All right. Okay, so welcome to session 3, everyone. My name is Raeann Robinson, and I am the operations manager for the Arizona Cancer Registry. So short presentation for you guys today. We're just going to review how the hospitals use WebPlus. We'll go over some data file submission expectations, and then just give a brief update on how the operations team is doing, and then briefly touch on critical data changes. So currently we have 171 individual users registered to use our WebPlus portal. So 37 of those user accounts belong to hospital cancer registry staff, and 134 are clinic staff that use the portal to send melanoma cases over to the cancer registry. So the dermatology offices use WebPlus a little bit differently than what the hospitals are used to. So for the dermatology office users, they log into the portal and they're directed to a demographics screen where they go through and they input things like the patient's name, their address. They text out the patient's primary site and histology for us. And then they go ahead and enter the reporting and surgical physician codes. And then they enter various dates such as first and last date of contact, and just a few other miscellaneous fields like vital status. So from there, they release that case abstract to us, and then they go in and use that same file upload button that you guys are used to, and they use that non-NACER file upload to send any supporting documentation so that our operations team of abstractors can then go in behind the scenes and finish abstracting that case. They go in and complete those first course of treatment codes and make sure everything matches up and is good to go. And once they've reviewed that case and finalized the abstract, from there, that's how the clinic cases then get moved into the Arizona Cancer Registry's main database. Once the clinic case is added to our main database, the ops team goes in again, and if necessary, they complete any case consolidation that needs to take place for that incidence of cancer. So for example, if there's 2 different clinics that worked on the treatment and diagnosis for that patient, they would work on the case consolidation for that record. Or maybe it was a clinic and a hospital involved in that patient's treatment. So then they would merge that case with your guys' abstract that you send in. So there are 100 and, like I said, 134 clinic WebPlus users, and they are spread out across 17 different dermatology organizations. And like Georgia mentioned, that doesn't sound like a lot, but these organizations can have multiple locations. So one of our larger ones, for example, they have 9 different offices throughout Arizona. And altogether, these 17 dermatology organizations report for 151 individual dermatology providers in Arizona. So we plan on continuing to expand WebPlus to capture cancer cases diagnosed and treated in the outpatient setting. We know we're only about halfway through our progress list of onboarding dermatology offices that are required through our mandate to report electronically. So we're going to finish onboarding the rest of those dermatology offices. And then from there, we plan to expand into urology and other providers at cancer treatment centers and surgery centers. So For those who are not aware, maybe you're not responsible in your registry for doing the monthly file submission upload, but if you're not, this is what the login screen for WebPlus looks like. This is how we now receive our monthly submissions from hospital registries. And this is a portal that is created and maintained by CDC's NPCR program specifically for essential cancer registries. So when you log in, here is an example of what you see. If you are one of those folks that reports for multiple hospitals, then you would see each one displayed individually. And this is my little reminder that if you do have multiple hospitals, please be cautious when you're selecting that file upload button, that you're selecting it underneath the name of the file you are actually, the name of the hospital you are trying to submit for. So from there, you get redirected to this menu screen, and they select the new upload button. And then this is the screen that you see. So where it says AZ Test Hospital, it would say your hospital's name. And then in the parentheses, it has your Arizona 3-digit assigned number. So that's another way that you can confirm that you are uploading to the appropriate hospital. If, like I said, if you're one of those folks that have to submit for multiple hospitals. So we have converted to version 25, both our ACR database and WebPlus. So if you are in version 25, please select that NACER version 25 radio button when you upload your monthly submissions. WebPlus will automatically run your file through ACR edits and provide you with a report detailing if all your cases pass edits or not. The non-NACER file option is what you would select to send files that if you're in version like 23 or older, or if you are needing to send us a different file format. So for example, like your critical data changes. So moving forward, you can actually start sending those, and we prefer that you send them through WebPlus. Historically, we used to do like SFTP or secure email. But the WebPlus portal is secure. So we would prefer now moving forward that you guys use that non-NACER file option to send us your critical data changes or any other Excel's files, or I know sometimes with Michelle, you guys send files back and forth for DCO. So here's an example of that edit report. You might not have seen this before if you're not the team member who does the file uploads, but this is what WebPlus generates if that file does not pass edits. So it'll tell you specifically which patient file and then what edits are popping up on that case that caused your file to be rejected. Another useful thing about WebPlus is that we can send you files. And so what you would do is from that main menu, the blue bar at the top, you would select download files, and then any documents we have released to you will display there. So previously, the operations team was reaching out to you guys via secure email to send you the outgoing critical data change files from the ACR. So moving forward with this next upcoming round of releases, we're going to start uploading them in WebPlus for you guys to go in and retrieve this way. If you have an employee who needs access to WebPlus, just shoot me an email and we can get their account created. The first thing we need to do is confirm that they have a 3-digit abstractor ID assigned by Juliet. And then from there, once that is done, we can create their account and get them their unique login credentials so that way they can start submitting cases for your registry. And we do still have the recording of the live demonstration video from last year's workshop that I can send them if they need that. So this is just a reminder of the expectations for your monthly file upload to the ACR. Please make sure that you submit on or before the 10th of the month. I do recommend submitting earlier than the 10th, so in case your file does get rejected, then you kind of have a bit of a buffer there to go back and fix those case errors and then resubmit before the 10th, so that way you're not falling outside of that grace period. If you do have a file that gets rejected, please know when you're going in and fixing those cases and then resubmitting, you need to resubmit that entire file, not just the cases that were rejected. Because when it's having edits and it's not passing, then WebPlus rejects that whole file. Like the cases that were clean don't like sneak through to us. So you need to resubmit that entire file for that month. And you should be doing that resubmission before the end of that same month. Okay, so enough about files. As you've heard, this is the breakdown currently for our operations team. We have three full-time cancer data specialists, Sarah, Mike, and Jordan. And you're used to hearing from these ladies when they send you those outgoing critical data changes. So if you ever need help with how to navigate those critical data change forms, you can reach out to any of us and we can help guide you through that process. So hospital registries in Arizona are required to submit critical data change forms to the ACR. Right now, the way the instructions are written, we ask that you send them to us every other month. Each hospital registry team should be tracking updates made to cases that have already been submitted to the ACR, so that way we can ensure our database matches your hospital database. This directly impacts our ability to properly link cases for updates. So it's really important that you guys follow through in sending us these forms. And as I mentioned earlier, we will now be exchanging them to and from hospital registries via WebPlus. So if you're not sure what changes should be logged on these critical data change forms, I have them listed for you here. This chart is also available in the instructions form that is on our website. So if you have already submitted a case to the ACR and you go back into that case and you update any of these fields that you see on the right-hand side, you should then be completing a critical data change form and sending that in bi-monthly to us. So here's a screenshot of our website, and this is the page where you can download both versions of our critical data change form that we have available, as well as the instructions. The instruction page goes over what the purpose is of each column in the Excel format of the critical data changes, and then how to use the different drop-down columns in that version if you're not familiar. And then it also goes over the PDF format version that we have available as well. And before the end of today's presentation, I'll pop the link in the chat to this website so you can go grab those forms if you don't have them already. So you've seen this image before. I sneak it in almost every year in the workshop in my presentation. This is an example of the Excel format of the critical data change form. This is the outgoing, you've probably seen it because this is the version that we use as our outgoing critical data changes. So just please remember when you're sending your critical data changes into us, especially with first course treatment, to please provide the complete information so we can properly update the record in our database. We need to know what codes you changed and the text supporting that code that you entered. And it's also helpful to us if you confirm which facility it was that performed this treatment, because sometimes you guys report for multiple hospitals. And I've noticed some folks will track all of their hospitals on one sheet versus doing a separate sheet for each hospital. So if you're doing it that way, I do need you to clarify which hospital location did that treatment. This information should also be included on the PDF format for the critical data changes if you continue to use that version of the form. And I really just want to emphasize that we are really dependent on the information that you put in those critical data change forms. Like we obviously don't have access to the patient's chart like you do. So the only thing we can see is what you give us. And we really want to make sure that our database at the central registry, like I said, is matching your database. So that way when you send any potential future sequences or updates for that patient, we can ensure things are properly linking and updating appropriately. Unfortunately, this information does not get automatically updated in our system. Us in the operations team, we have to manually update these changes. If you don't have access to Excel, or maybe you just don't like it, we do still have the PDF version available. This is when critical data changes were first rolled out. This is what they were used, was the PDF version. So that's still available for you if that's what you're comfortable with. So far in the calendar year 2025, the ACR has only received 131 individual critical data changes from 12 facilities. And as you can tell, the majority of those changes have come from one hospital. And they've actually sent more since I made this chart, so their number is actually even higher than what you see on the screen. They do exceptionally well with completing critical data changes. But the point of this slide is to just show you guys how overall we have not been receiving these critical data changes in the way that we should be. And as I mentioned, it unfortunately creates issues with the system doing appropriate linkages and updating for patients. These are not new. They've been required by the ACR for years. And so we really should be receiving critical data changes from every hospital registry. And as you know, we are unable at this time to process follow-up files, and we're working on the corrections files. So right now, it's important that we have hospitals follow through with this process and send us their bi-monthly critical data changes until we can get those things fleshed out in 2026. This information does, impact follow-up rate, and so we really want to prioritize making sure that you guys get this information sent over to us so we can make sure the databases match. Thanks for joining today. Appreciate you guys.
Thanks so much, Raeann. And I just wanted to make one more plug for those critical data changes. I know we've talked about our call for data requirements, and part of those requirements involve running all our cases through a CDC program called Match Pro, and it matches up patient level data items, tumor level data items, and it's much more sophisticated than the process that Rocky Mountain uses to do matches. But if we don't have the information in the abstract corrected because we didn't receive critical data changes, then we have to still manually review those cases. And it's an intensive process as we get ready for call for data, and even reviewing them quarterly. It's very helpful if we get those updates, because Rocky is not great at matching up the same patient if any of those demographics items are different. And it's not great always at matching up tumors if any of those tumor data items change. So lots of reasons why it's helpful if you send us your critical data changes. And thanks, Raeann, you did such a great job of illustrating all of that. So next, we are going to go on to our formal Q&A session. And we do have a few questions, but feel free to submit. And you should be seeing the formal Q&A session slide right now. So great. I also wanted to make one more plug. I've put the link for evaluating today's session in the chat a couple of times. If you can fill that out, that is very helpful for us. So thank you in advance for evaluating and leaving us any feedback that you have for us. So, okay, let's go over some of these questions in the Q&A chat. And any questions that we don't answer here, you'll be able to see the answers when we send out the complete Q&A document that we'll be sending out after session 4 next week. So first question, if we've submitted an abstract and then identify a correction, currently we are only expected to submit a critical data form since the correction issue is being reviewed, correct? And I think, Raeann, you covered this, but if you want to speak to that, that would be great.
Yes, so that is correct. Unfortunately, right now, we're not processing correction files or follow-up files, so we do need you guys to use those critical data change forms for the time being. Yeah.
Very helpful, and thank you for reviewing that. This question, I believe, is based on Georgia's presentation. How is the expected number of cases calculated for each hospital every year for reporting? So Georgia, if you're able to speak to that, I would appreciate it.
Yeah, so it's a 2-year average, and it's based on your last 2 complete years that you've reported. And so that's pretty consistent with how we used to do it when Keith was producing the reports. And so we're keeping that same formula as a 2-year average.
That makes sense. And now with the dashboard, they'll be able to see even more often where they're at with timeliness and completeness. So that will be very helpful. All right, next question. I appreciate the opportunity for the CEIP credits. Do you think in the future we may go back to doing an in-person all-day meeting to obtain most, if not all, of the CEIPs at one time, not to mention peopling? So we've gone back and forth about that, and at this point, we don't have plans to change to an in-person version of this workshop. And mainly that is because we have so many contractors who work out of state, and the information that we provide at this yearly workshop is important for any abstractor who's abstracting cases for Arizona. So we've tried doing some surveys before, and maybe we'll do another survey to see how many folks could actually attend an in-person workshop if we offered it. And so far, the response has overwhelmingly been that there just isn't the support, especially from some of the out-of-state folks, to be able to travel to Arizona for a meeting. But we'll continue to take a look at that. We just need to make sure that as many folks as possible are able to view these sessions. So for right now, I'll be making sure that you know of any CEIP opportunities that we're able to offer, but this meeting will be virtual until we're able to figure out a different way of doing this workshop. So hopefully that answers the question. Next question involves class of case 32s. And there's some concern about ODSs from different facilities who may be duplicating each other's work, because we do require these non-analytic classes of case to be submitted. And so I was hoping either Georgia or Raeann or both of you could speak to why it's so important that we receive these class of case 32s, and why that decision was made that for Arizona, all class of case 32s are required to be reported.
I think our response is kind of twofold. We don't look at class of case in terms of reportability, in terms of, okay, let me back up. When we submit a file nationally, we only submit Arizona residents. And so we don't take a look or take into account what the class of case is when we submit data to the national folks. So we need as complete a record that we can get from registrars, from hospital reporting, in order to make that what we call a complete record. Because those, even though it's a 32, we still report it to CDC, and it becomes part of our data submission. So that's key. What's happening nationally is there is a discussion, not necessarily just about non-analytic cases, but about partial records. Because, for example, lab reports that we get, for example, we get these pathology reports, and sometimes those path cases are not reported by a hospital. And so we create a case report out of that path record. And once you start doing that, then the record potentially becomes less complete in terms of you don't have the treatment plan. You may not even be able to stage the case. It depends on how much information is on the path report and what additional information you get from that path lab. So there's a lot of discussion nationally about these kinds of we're calling them partial records, but I think they're using the term modular records at the national level. So it's going to be interesting to see what the outcome of this, and it may be that they end up with what we call a minimum data set, so that the incidence of the case is being reported, but not necessarily all the treatment information. So it'll be interesting to see what happens in this next year related to this issue. Just know that it is a national discussion, but for now, we expect you to try to complete all the required data items, even though many of those data items may be unknown for any of the non-analytic cases.
Thank you. That does help explain it. Next question is, does timely reporting of cancer vary by primary site? For example, some breast cases and many heme cases have extended treatment plans lasting over 6 months. Does the timely reporting improve for sites where the treatment plans have shorter treatment implementation or duration?
I'll take a stab at this and you guys can join in if you'd like. We've never looked at it by primary site, but my guess is that if we did, we would probably see differences in timeliness. I don't know if the college still has some form of rapid reporting. And so my guess is, if so, that we probably get those cases in quicker compared to other primary sites, because hospitals tend to prioritize what they have to submit to the college. So my guess is, yeah, we probably see some differences related to that.
That would make sense. Next question is, in regards to the 2026 fiscal year funding, and I think that's at the federal level, is that decision on hold only due to the shutdown, or was it still unapproved before that?
It has not been approved due to the shutdown, is my understanding. Yeah. So, yeah, a budget hasn't been passed. Normally, they do continuing resolutions that will last several months, so it would take them into the new fiscal year, but this time it was not passed, that continuing resolution.
Well, I know we're going to be keeping our eyes open here at the ACR to get any updates on what's going on with that. So we'll communicate as information is available. Thanks, Georgia.
Mm-hmm.
Next question. Do critical data changes apply to non-analytic classes of case?
Trying to remember, Raeann.
So our instructions currently do not say that it only applies to one or the other. So I'm going to say yes, because it doesn't specifically say they don't.
Okay.
And I know when we're doing that Match Pro deduplication process, it does look at non-analytics as well as it's matching up cases.
Right. Yeah.
Next question. When we receive the quarterly ACR, I'm assuming that's quarterly ACR report on timeliness and completion, but the person who submitted that, feel free to clarify if that's not what you meant.
I think he's talking about the quarterly outgoing critical data changes.
Oh, okay.
Yeah.
That would make sense. So when we receive the quarterly outgoing critical data change forms, do we have to submit information back to the state that the corrections were made to our abstract?
So I can take that. Yeah, I know he's
Thank
asking.
you.
No, once we send you the change that we made, and if you need to make that update, if you haven't already, to your system, then you're done. You don't have to then send us back a form stating that you completed that change. You only have to send us the change, when you've yourself changed something and we, haven't communicated that we've also made that change. So no, you don't have to send them back to us.
All right. Next question is, it seems like there are more and more class of case 32s. And this person mentions that it adds more work on facilities already working to complete the case. How can we reduce those backlogs? And I know we've had some discussions on this, and Georgia has presented before on best practices in terms of how to get caught up. Georgia, I'm not sure if you want to take this one and add anything.
Well, when I'm not sure I understand Rose's question because she's talking about assuming the responsibility of reporting cases for other facilities, because we no longer use the tracking system, which, remember, you used to fill out the form and then we look up the case and see if it was reported and determine whether you reported it or not. So we're not using those forms anymore. So every hospital is currently reporting all their non-analytic cases. And this, unfortunately, we can't avoid when a case is reported by multiple facilities, because we tried that and it was creating, we had many hospitals not even reporting their non-analytics, and it was becoming a bigger burden on us, on many hospitals. And so we made the decision long ago, or a couple years ago, to no longer do those tracking forms and require all non-analytic cases to be reported. And that's currently where we're at. I mean, we may revisit it at some future date. But unfortunately, you're right, it's duplicate reporting and it's something we cannot avoid right now.
And then this last question that I see in the Q&A is also talking about non-analytic cases, and I'm going to take a stab at answering it, but anyone else feel free to jump in if there's something that I'm overlooking. So talking about non-analytic cases, are we just wanting first course of treatment information, or are we looking at everything, including subsequent treatment and outcomes? So we don't require you to code subsequent treatment. The only place that's recorded is in text, and that's on the facility to determine if they want to include that information in the text. But even for analytic cases, we do not require you to code anything beyond first course of treatment. But I will say that there are a lot of gray areas, and people oftentimes get confused about what is actually first versus subsequent treatment. So I would say be sure to read through STORE and make sure that what you consider subsequent treatment is actually subsequent treatment, because that can oftentimes be a place where abstractors can get themselves into trouble.
Also, too, when you're completing critical data change forms, we specifically only ask for updates on first course treatment. So if you're worried about, applying that to critical data changes, no, we're only asking for first course treatment updates on critical data changes.
So IRIS, bottom line, only first course treatment.
Those are all the questions that I see, and we'll make sure that we get you that updated Q&A document once we're done with all of our sessions. So unless I notice anything else, I believe that is it for today, and we're hoping that you will be joining us for the final session of this year's annual educational workshop, and that will be next Thursday, the 23rd. So thank you all so much for being here, and I hope you have a wonderful rest of your week, and see you next week.